Yeah, today I'll be discussing what you need to know about your prostate biopsy on needle biopsy. It's a great pleasure to be able to speak to the group. Um, and I'm currently at Advanced Uropathology of New York, Global Consultation Services, and we'll discuss later how you can reach me out to send a consult. So first we'll talk about prostate cancer. Probably the most important thing for the pathologist is grading of cancer. The Gleason grading system was named after Donald Gleason, who was the chief of the Department of Pathology at the Veterans Hospital in Minnesota. And it's important to recognize that it originated a long time ago, 1967 to 1973, over 50 years ago. Obviously, a lot has changed in prostate cancer knowledge since then, leading to significant modifications of the Gleason system. So this is the original Gleason system, where Gleason came up with 5 architectural patterns, one being the most differentiated or most indolent, less aggressive, ranging up to 5, which is least differentiated and most aggressive. And what Gleason noticed was often tumors had more than one pattern. So what he came up with, which was unique for grading systems, was to say what's the most common pattern. For example, if 4 was the most common pattern, and then say what's the second most common pattern. Let's assume it was 3, and adding them together. So in that scenario, you would say 4 is the most common. It would be 4 plus 3. If a tumor is all one pattern, for example, 3, in order to keep it in line with the other grades, you just double it. So if a tumor is purely 3, it ends up being a 3 plus 3 equals 6. So in Gleason's time, tumors could range from a 1 plus 1 equal 2, or pure 1, to a 5 plus 5 equal 10, a pure 10. Just one example to show how much the grading system has changed over the years. Even in the 1990s, 22% of prostate needle biopsies had as the highest grade a Gleason of 2-4. Currently, there should be no prostate biopsies graded as 2 through 4, and virtually none graded even as a Gleason score of 5. So the 2 major consensus conferences that changed how we grade prostate cancer was first in 2005, one that I led, and then in 2014, also one that I was involved with. And so on the left is the grading system I just showed you that was Gleason's. On the right is kind of the current schematic diagram of how we grade prostate cancers. Even though there is this 1, 2, and 3 on the right, for the most part, 3 is the lowest grade we give. And in terms of pattern 3, in Gleason's time, 3s were more complex. They included cribriform glands, and I'll talk about cribriform glands shortly, but these glands that look almost like Swiss cheese on the far left. And what you can see in the current schematic system, grade the Gleason pattern 3 is very uniform, very simple. It looks like a bunch of little donuts. And it's basically just individual well-formed glands. And think of a gland as almost like a beach ball, and if you cut it, you'll have a hole in the middle, and that's what makes these little glands. Gleason pattern 4, back in Gleason's era, was mostly these irregular cribriform glands or irregular Swiss cheese. And currently, it's more complex in our current system. Some of them are these cribriform structures. Some of them are fused glands where the glands kind of merge together. And some are glands that are just not very well formed or poorly formed glands. And we'll talk about these different patterns of Gleason pattern 4 shortly. Again, different types of pattern 4, poorly formed glands, fused glands, and cribriform glands, which comes from the Latin word of sieve. Now, amongst these patterns, it's been shown that reproducibility amongst pathologists is lowest for poorly formed glands. So one pathologist may say, yes, I think there are poorly formed glands in pattern 4. Another pathologist might look at it and say, no, they're not that poorly formed. We're going to call it pattern 3. So that's a problem. It is highest reproducibility amongst pathologists for cribriform glands. So when somebody sees a cribriform gland, one pathologist sees it, typically another pathologist will agree. Gleason pattern 5 is the most poorly differentiated, where the tumor really doesn't make any glands anymore. You either have solid sheets of cells or individual cells. And the only thing I'll talk about with Gleason pattern 5 is that we've done several studies to show that when I think there's Gleason pattern 5 present, often it is underdiagnosed by the outside pathologist. I think there's a hesitancy by pathologists to give patients the worst potential grade possible, even when it's present. And I think it is important that when Gleason pattern 5 is present, to note it in the report, because that's going to be important for treatment and prognosis. So some of the problems with prostate cancer grading. So routinely, and every day I'm looking at many prostate biopsies, many sent in from other institutions. So when I regularly review prostate cancer biopsies, either sent in by patients or clinicians, I will often change the grade, either from a 6 to a 7 or maybe a 7 to a 6, which, as we'll talk about, is critical for active surveillance. But also, even if you're not on active surveillance, I also frequently change higher grades as well, which can impact treatment and prognosis. Probably the most important thing on that pathology report, in addition to making sure there is cancer present, is that the grade is correct. And that's the foundation for optimal treatment for prostate cancer. Just to show you a problem with grading, there was a large study done looking at 2 different patient cohorts. And what they found was about 8% of biopsies that were called a 3 + 4 = 7, when the radical prostatectomy was done, the whole tumor was looked at, they couldn't find any 4. It was all 3 + 3 = 6. And what they concluded, and what I agree, is most likely this resulted from the biopsy being overgraded. And in fact, the biopsy was probably a 3 + 3 also. And that led to overtreatment, because if that patient had a biopsy of 3 + 3, very likely in today's practice, they wouldn't have had a radical prostatectomy. So this emphasizes the importance of accurate biopsy grading. So why is there discrepant grading? Most pathologists are good diagnostically and most will grade accurately. However, a significant minority will not, either due to inexperience, lack of skill, which can result in blatantly in error. But some cases, grading can be subjective. And in these cases, if there's a borderline case, again, you want to rely on a pathologist with the most experience. Let me briefly touch upon an issue where there's been controversy about calling Gleason score 6 cancer. And that's relating to the fear of term in the word cancer. So potential is that cancer, if you're diagnosed with cancer, can drive overtreatment. Fear of death from cancer likely does play some role. And if you could remove the label of cancer, maybe that would reduce unnecessary treatment for low-grade prostate cancer. Just to show you a fact which emphasizes this point, in the past, about 8% of men, when I was at Johns Hopkins, on active surveillance, opted out, underwent definitive therapy, whether it's radiation or surgery, even though they still qualified for active surveillance, just due to anxiety associated with living with cancer. So these proponents who say this fear of cancer drives overtreatment has basically been proponents to say we should rename Gleason score 6 as non-cancer. And this is an ongoing debate. These are just some of the articles and studies I've been on where this debate has gone on in the literature, but this debate continues today. So let me explain why my personal opinion as a pathologist is that we should call Gleason score 6 cancer. First of all, under the microscope, and even in terms of its molecular findings, Gleason score 6 is cancer. Gleason score 6 looks like has higher grade cancer under the microscope. It has many of the molecular hallmarks of prostate cancer. When you look under the microscope, Gleason score 6 is locally invasive. It creeps around the prostate, which benign glands don't do. It can even spread out of the prostate and rarely invade the seminal vesicle. All hallmarks of more aggressive disease. But probably the most practical reason why I favor keeping Gleason score 6 as cancer is the problems of upgrading of Gleason score 6 on biopsy. So 20 to 30% of the time when Gleason score 6 is diagnosed on biopsy, and let's say a radical prostatectomy is done, the radical prostatectomy shows higher grade tumor. So it's upgraded. Even if you look at low risk prostate cancer, which is just 1 to 2 cores, no core has over 50% cancer, the PSA is low, there's a 15% risk of having worse cancer that was missed on the biopsy. Even if you look at lesions that weren't even seen on multiparametric MRI, PIRADS 1 and 2, and you have a Gleason 6, there's still a 20% risk of upgrading over time. So the problem, if you do not call Gleason score 6 cancer, is there's potentially 20% or so of the time, you risk mislabeling a patient who has unsampled more significant cancer. These patients, if we rename Gleason score 6 as not cancer, we would be told they don't have cancer. And in my opinion, there would be a greater risk of them not being followed closely with repeat biopsies, repeat imaging, and follow-up visits. The other reason why think we should still be calling Gleason score 6 cancer is I think patients are becoming more knowledgeable about the disease. And don't just have this knee-jerk reaction that all cancer is horrible cancer. And I think that has been shown with a couple of studies, over 150,000 patients, where we see the number of radical prostatectomies with Gleason score 6 decreasing over the last decade or so, from almost 50% to 14%, another study down to 8%. And this is, I'm sure, decreasing even more with more recent years. So I think patients are now recognizing more and more that active surveillance is the preferential treatment for Gleason score 6 cancer, even though we're calling it cancer. The other important thing is Gleason score 6 is not the only important parameter to look at. For example, you can have a Gleason score 6 with a PIRADS 5 lesion on MRI, which is very worrisome, a Gleason score 6 with a very high PSA, a rapidly rising PSA, a BRCA2 mutation, which is associated with aggressive disease. If we call Gleason score 6 not cancer, would we call all of these not cancer, even though these are at even higher risk for more aggressive disease? So I think we still should call Gleason score 6 cancer. But I agree, we have to change what patients think when they hear that they have a Gleason score 6 cancer. And that's mainly up to the urologists. They're kind of the gatekeepers, the first ones to talk to patients when they're diagnosed with prostate cancer. They have to reassure patients, educate patients. But as pathologists, I've been a big proponent to modify how we report prostate cancer to more accurately reflect their behavior. So as I mentioned, currently Gleason 6 is the lowest grade we give to prostate cancer, even though the scale theoretically goes from 2 to 10. It's confusing to have a grading system where 6 is the lowest grade. Every other grading system in the human body for every other tumor, grade 1 is the lowest grade, and that's intuitive. Gleason score 7, if you just tell somebody they have a Gleason score 7, that's also misleading because, as I mentioned at the onset, Gleason score 7 can be a 4 plus 3 equals 7 with more 4 than 3, and that has a much worse prognosis than a tumor with more 3 than 4, which is also a 7, but it's a 3 plus 4 equals 7. Gleason score 8 through 10 are often just lumped together as high-grade disease, which, as I'll show you, is also incorrect. So in 2013, we came up with a more patient-centric group grading group system, where you break grades into 5 groups. Grade group 1 is the best grade, most indolent. Grade group 5, the worst, most aggressive. Grade group 1 is less than or equal to 6. So anything from a 1 plus 1 equal 2 to a 3 plus 3 would all be grade group 1. Grade group 2 is 3 plus 4. Grade group 3, 4 plus 3. Grade group 4 is Gleason 8, and grade group 5 is 9 through 10. And that was based on data. And that showed that if you have a grade group 1 and you have a radical prostatectomy, you have a 96% cure rate. You might wonder why it's not 100%, because as I'll tell you shortly, if you have a Gleason 6, it's incapable of spreading out of the prostate. But some of these Gleason 6s had positive margins. The surgeon couldn't get around the tumor for various reasons, and that's why 4% of them recurred. Grade group 2 or 3 plus 4 equals 7 still has an excellent cure rate, 88%. If we think of any other cancer of the body, an 88% cure rate is amazing. Grade group 2, 4 plus 3 equals 7, even though they're both Gleason 7, drops significantly down to a 63% cure rate. Grade group 4, Gleason 8, 48% cure rate. And grade group 5, 9 through 10 has basically twice as bad a prognosis as grade group 4 with a 26% cure rate. The grade groups have correlated not just with follow-up after radical prostatectomy, but basically every other parameter that we can think of to measure prognosis in prostate cancer. So the grade groups, I think, do a better job than the Gleason system and how we report prostate cancer. Grade group 1, as opposed to a 6 out of 10, it's intuitive, excellent prognosis, no metastases, gets away from the whole problem of grade groups 2 through 6. It's all just grade group 1. Grade group 2, as opposed to a 7 out of a 10, 7 out of 10 sounds not that great. It's closer to a 10 than, for example, a 1. But grade group 2 is closer to a 1. It has a very good prognosis, rare metastases. Grade group 3 forces people to separate out 3 plus 4 versus 4 plus 3. Similarly, grade group 4 forces to separate out 8 versus a 9 through 10. And then grade group 5, whether you have a Gleason score 9 or 10, really doesn't make a difference. They all behave quite aggressively. It's been recommended to use the new grading system along with the Gleason system, at least for the current time period. So the way we would report, for example, 4 plus 3 equals 7, is we'd say, adenocarcinoma of the prostate, Gleason score 4 plus 3 equals 7, but then put in parentheses after it grade group 3. The thought is eventually we may just report grade group 3, but currently that's not the practice. Now, even though that's, I think, an improvement over what's been in the past, we can do better. And the major pathology societies have recommended to report percent pattern 4 when you have a Gleason score 7 on biopsy. So in the past, for example, it was very simple. You might just say there's adenocarcinoma of the prostate, 3 plus 4 equals 7, and you say how much cancer there is. But now, let's say if you had a 3 plus 4 equals 7 with just a little bit of 4, you would report it as adenocarcinoma of the prostate, Gleason score 3 plus 4 equals 7, and note, for example, 5% or 1% Gleason pattern 4, and then the volume. But you can also have a 3 plus 4 equals 7, almost up to 50% pattern 4. And in that case, in a different case, you would report it as adenocarcinoma of the prostate, Gleason score 3 plus 4 equals 7, close to or approaching 50% Gleason pattern 4. So why is it important to give the percent pattern 4s when you have a 3 plus 4 equals 7 or grade group 2? And the reason, even more and more nowadays, is that active surveillance, while becoming almost standard therapy for Gleason score, is increasingly being used for selected favorable intermediate risk patients, typically low volume grade group 2, so low volume 3 plus 4 equals 7, depending on a lot of factors, life expectancy, other clinical and radiological factors. And in this setting of a 3 plus 4 equals 7, when you're thinking, can this patient go on active surveillance, reporting the percent Gleason pattern 4 can be critical. So let me show you two scenarios where one, you might recommend active surveillance, the other not. So if you had a 3 plus 4 equals 7 with less than 10% pattern 4, that today could be a good candidate for active surveillance, again, factoring in other parameters. But if you had a 3 plus 4 equals 7 with close to 50% pattern 4, that's a borderline 3 plus 4 and 4 plus 3. In my opinion, for most of the vast majority of the patients, that wouldn't be a good candidate for active surveillance. But if you just reported it as 3 plus 4 equals 7, like we used to, and still some pathologists do this, you have no idea which type of 3 plus 4 you have. There's also a rationale for reporting percent pattern 4 when you have grade group 3 or 4 plus 3. And that's mostly for radiation therapy. So if you have a grade group 2, which is 3 plus 4, that's considered favorable intermediate risk. Most of those patients do not get hormone therapy prior to radiation. But if you have a grade group 3, that's considered unfavorable intermediate risk, 4 plus 3 equals 7. Those patients often get hormonal therapy, again, depending on other parameters. So take, again, two different patients. One has a 4 plus 3 with 90% pattern 4. That's a 4 plus 3 bordering on a grade group 4, 4 plus 4 equal 8. That patient you would treat aggressively with hormone therapy prior to radiation. But if you had a 4 plus 3 with 60% pattern 4, that's a grade group 3 bordering on a grade group 2. Typically, you probably would not give hormone therapy in that setting. So I've emphasized grade, which is the most important thing. The other thing that you will see on your pathology report is a quantification of cancer. So one thing you typically will see will be the number of positive cores. The only time you might not see the number of positive cores, if cores are all fragmented, sometimes you can't be sure how many cores are positive. And in that scenario, what I will say is the tumor occupies 20% of the fragmented tissue. So even though you try to give the number of positive cores, sometimes it's not possible. The other way to give, in addition to the number of positive cores, you try to give a measurement either how many millimeters of cancer there are or the percentage of cancer per core. There's no real right way, one way or another, to do that. A lot of studies have shown they're about equivalent, but you may see different reports, one doing millimeters of cancer, the other doing percentage of cancer per core. Again, both are fine. But what I would emphasize, in general, the extent of cancer is not nearly as critical as the grade. So for the most part, when you're reading your pathology report, don't focus too much on the extent, look more at the grade. Now, another issue that I'll bring up, because it can lead to a discrepancy that's confusing to patients, is when the cancer is discontinuous. So that red that I'm showing here is a core, which is basically a thread or of tissue that the needle takes out. And I've shown that in this particular example, there's only 2 tiny spots of cancer represented by the blue dots. And this is not that infrequent to see cancer not just as a sheet going all the way up and down the core, but there can be intervening benign tissue in between the cancer. And this, you could come up with 2 different ways that a pathologist would report this case. One, they could look at how much cancer is involved in the total area of that core. And if they did that, you'd say cancer is involved in 5% of the area of that core. You divide the blue by the total red. But the other way to say it is that there are small foci of cancer, small little bits of cancer, discontinuously involving 80% of the length of the core, meaning you measure from one end, one blue dot to the other and saying that's 80%. We've done studies and other studies have shown that in the majority of cases, when you see something like this, 2 spots of cancer separated by a lot of benign tissue, and you look at the whole prostate in that setting, in the prostate, it's one big tumor that the needle biopsy is just sampled an area where there's cancer, benign cancer, but overall, it's a bigger tumor. So based on that, the way I report these findings is that this is 80% of the length of cancer, not 5% of the total area. Another thing you'll see on a pathology report is whether there's perineural invasion. It is a predictor to somewhat of prognosis. It can predict exoprostatic extension. It's not 100%, but it has some prediction at radical prostatectomy, and it has some prediction of progression following external beam radiotherapy. It is more reproducible than grading. It is recommended to include it on your biopsy reports. But just like with measurement of cancer, what I would emphasize is that perineural invasion is not that critical for patient management and typically will not affect eligibility for active surveillance. Now, I'm going to introduce another term and describe this, which is very important and is more aggressive than, for example, perineural invasion. That's intraductal cancer. So first of all, let me just explain kind of what a duct is in the prostate. One way to think of the benign, the non-cancer prostate, is think of it as a bunch of pipes, a bunch of hollow pipes that have a bunch of branching all over the place. And all those pipes branch, and at the end of those branches are basically little grape-like units, which are the glands that I talked about, little balls that are hollow. So you have this duct system, these pipes in the prostate. And then cancer basically is in between these pipes and in between the grapes, creeping all around. That's prostate cancer. But what can uncommonly happen is that the creeping cancer, the invasive cancer, can literally break into these tubes, break into these pipes, and start growing into those pipes. And that is what we call intraductal cancer. However, uncommonly, intraductal cancer can only be within those pipes. Where you have no invasive cancer anywhere else, it's kind of a precursor to cancer, what we call an in situ cancer. Very uncommonly, you get, for example, the whole prostate out at radical prostatectomy, and there's only intraductal cancer. There's no invasive cancer. In that setting, those patients are 100% cured because the cancer that is confined within those pipes doesn't have the potential to spread anywhere outside the body. Most cases under the microscope, when we see that intraductal cancer growing within the ducts, growing within those pipes, we'll also see next door to it under the microscope invasive high-grade cancer. In that setting, when we see intraductal cancer associated with invasive high-grade cancer, which is most of the time, we grade the intraductal cancer, we consider it large cribriform glands of Gleason pattern 4. Many pathologists will just lump intraductal cancer and cribriform cancer together, not even try to prove if intraductal cancer is present. However, and this is what is the current practice where I am, some clinicians want to know if intraductal cancer is present, even if there's more aggressive cancer somewhere else. And that's because that can affect whether to do surgery or radiation. And our radiation oncologists tell us that if intraductal cancer is present, that will actually affect how they do their radiation and what dosages they give. Now, in the rare case that a biopsy, if you get back a biopsy report and it says just intraductal cancer, it doesn't say anything about invasive high-grade cancer. In that setting, we don't grade it. We don't consider that as large cribriform cancer. It's all this precursor cancer confined to the ducts. If you get a case which shows only intraductal cancer, there's no invasive cancer, most cases you'll undergo a repeat biopsy to try to see if there is unsampled higher grade invasive cancer. But sometimes, even if you don't find a higher grade invasive cancer, most experts, myself included, would recommend treatment. And that's because even if that intraductal cancer right now is confined within those pipes and ducts and can be cured 100% of the time, it has a higher risk of breaking out of those ducts and invading, at which point the prognosis becomes poor. So let me go a little bit more into active surveillance. So when you talk about criteria for men for active surveillance, one is age to some extent. The older the person who has a shorter life expectancy, you feel more comfortable doing active surveillance on, even if they may have somewhat more aggressive disease. Somebody who's relatively young in their 50s who has 30, 40 years of life ahead of them, you want to be more stringent probably for the criteria that you allow for active surveillance. Something that I have found, obviously talking to patients, is patient preference. There are patients who really strongly want active surveillance and are very engaged in it and are comfortable with it. And then there are other patients who basically say, I just want this cancer out of me. I don't want to wake up every day thinking there's a cancer in me. Maybe my father died of cancer, my relative died of cancer. I just want treatment. So patient preference obviously is important. How extensive that cancer is based on imaging or clinical stage is important. Needle biopsies, we talked about, I'll talk a little bit more. And then the other important thing is PSA. PSA can be kind of a global indicator of how extensive the cancer is, because sometimes the biopsy or imaging may underestimate the cancer. And if the PSA is very high, that's giving you a clue, a signal that there's probably more cancer there that was just missed by the biopsy or the imaging. And you'll see the word PSA density a lot. I'll briefly describe that. It ends up being a better measurement of PSA in some cases than regular PSA. So it seems like a long time ago, but in 1994, I was part of a study that was the first study to basically try to come up with well-defined criteria to predict cancers that could undergo active surveillance. And at that time, and you have to recognize 1994 was quite a long time ago, the thought of active surveillance not treating prostate cancer was a radical concept. Many experts, probably the majority of experts in the field, majority of urologists, for example, did not want to do active surveillance and thought it was the wrong way to go, that patients were going to be dying left and right by doing active surveillance. So when we came up with a model, preoperative model to predict who would be the best candidates, we call it very low risk, for having active, which would be good candidates for active surveillance, we try to come up with the most stringent criteria where virtually every one of these patients would have good cancer for active surveillance. We wouldn't subject almost anyone to risk of being on active surveillance. So first of all, our criteria were the patients had non-palpable disease on rectal exam, which is the most common way that prostate cancer presents today. Gleason score 6, only 3 cores or 1 or 2 cores with cancer. No core had a lot of cancer. And then the PSA density, which is you take the PSA divided by the gland weight, which can be done on ultrasound or other imaging. It was less than 0.15. And the reason why PSA density is a better measurement, even benign prostate tissue makes PSA. So if you had a 100-gram prostate, a huge prostate, you could have a PSA of, that's 10, and your PSA density would be 0.1, 10 divided by 100. So the PSA density is low, which means don't worry about cancer. But just the PSA 10 by itself, if you didn't do the PSA density, would be worrisome for cancer. So PSA density is helpful when the prostate is either very small or very large. So when we try to predict who's going to be a good candidate for active surveillance, we talk about what's going to happen in the future. And if on the future they have worse pathology on the subsequent biopsy, we call it reclassification. We don't use the word progression. The reason why, progression implies that, for example, if you go from a 6 to a 3 plus 4 equals 7 on your second or third biopsy on follow-up, progression implies that that 6 became more aggressive. It progressed from a 6 to a 7. The disease changed in some way. But in fact, the vast majority of times when a 6 on the first biopsy ends up showing up as a 7 on a later biopsy, it's not that the tumor changed, but that 7 was there at the time of the first biopsy, it was just missed. So it's more sampling than anything else, why you have higher grade on a subsequent biopsy. And we call that reclassification. So one of the things you'd like to do is, can we predict when somebody's diagnosed and we're thinking of doing active surveillance, can we predict what's the chance of them having worse disease down the road? You could look at PSA on follow-up and say, does that help? And unfortunately, it really doesn't. So even though it's standard for all kind of follow-up on active surveillance to do PSAs, in general, PSA can bounce around a lot. So PSA can go down a little bit, can go up a little bit, but over time, the patients who have worse disease on follow-up don't necessarily have higher PSA later. The one importance of doing PSA for a man on active surveillance is to look for rapid rises of PSA. In that setting, when it's rapidly rising and continuously rising, that's worrisome that there may be something worse there. But if it goes up a little bit, goes down, goes up and stays a little bit at the same time, again, that's in a sense noise. It doesn't really have that much significance. Now, I'm not saying PSA is not useful. PSA is useful to help diagnose prostate cancer. Once you've been diagnosed with prostate cancer and being followed on active surveillance, PSA, with the exception of a rapid rise, isn't that helpful. We came up with a tool to try to predict who's at more increased risks of having worse disease if they're diagnosed with, for example, a Gleason 6. And the things that we found were important is if you were diagnosed before 2005 with the Gleason 6, you have a significant chance of having worse disease over time. And the reason is, if you remember, that first consensus conference and when we changed grading was 2005. So prior to 2005, things that were called Gleason 6 today, we would often call them higher grade. And that's why if you've been diagnosed with the low-grade cancer before 2005, it may not be accurate. Turns out the older you are, the greater the risk of having worse cancer. No one knows why. And it's not saying that every man with older disease has worse cancer, but there is a correlation. Your PSA density at the time of your last biopsy also plays a role. If you have a higher PSA density, you're at increased risk of having worse cancer down the road. If you have cancer bilaterally on both left and right side of the prostate, that increases your risk of having worse cancer. Low risk versus very low risk. Very low risk is, again, Gleason 6 with just a little cancer. Low risk is Gleason 6 regardless of how much cancer. That makes a difference. And then another thing that's very important is how many times you've been biopsied still with a Gleason 6. So if you're on active surveillance and you've had just your first biopsy of Gleason 6, that's not telling you that much because you haven't sampled the prostate that much. There could be worse cancer somewhere else in there that you'll find on the second biopsy, which we call a confirming biopsy, or on a later biopsy. But if you're somebody who's had, you've already had 3 biopsies, you've had 4 biopsies, they're all Gleason 6, what that's telling us is that, yeah, that's true. You probably truly have a pure Gleason 6, and there's not worse cancer there hiding somewhere. And what we found is you can give points to all these. So you say, let's say you're 70 years old, you come up here and you get, 28 points. You look at your PSA density, you go up there, you see how many points that is, when you're diagnosed, et cetera, et cetera. You add up all the points, and then you come down here and you say, what's a chance on a subsequent biopsy of having worse cancer, higher grade cancer? And what we found is that when we use this tool, 60% of the time we can predict that in 60% of the times, we can predict that somebody's going to have a low risk of their grade changing. And what that means is that in 60% of the time, using this calculator, we can reassure patients that they have a high probability that they'll stay on active surveillance based on their not being reclassified to worse disease. And then also we can start spacing out the repeat biopsies. So one of the things that we're now trying to do with active surveillance as we're following men longer and longer is initially you get a biopsy, it shows, let's say, Gleason 6. We do what's called a confirming biopsy about a year later to try to see, to the best of our knowledge, if that's accurate, that it's truly a Gleason 6, there's not worse cancer there. And then depending on what your urologist feels, depending on the imaging, your PSA, multiple factors, you try to start lengthening out the biopsies, maybe to 2 years to 3 years as you go on. Now, in addition to biopsy findings and all the other factors that I mentioned to decide whether to go on active surveillance, there's also molecular tests. And I'm just talking about one of them. There are others out there. I'm not trying to be a proponent of one test or another. But a test that is commonly used is the Decipher test. And in this study, what it showed was that using the Decipher test can help predict who has a chance of having a higher grade tumor on a subsequent biopsy, especially when you had a grade group 1. What it did show, however, or didn't show, was that if you had a 3 + 4 = 7, let's say, and you're on active surveillance, at least in this study, it wasn't that helpful to predict who's going to develop a 4 + 3 later on. So I'm often asked, should I get these molecular tests? How would you use them to help in decision making? So the way that I conceive of it, let's say you have favorable pathology, Gleason 6, and then you decide, okay, I'm still a little uncomfortable maybe going on active surveillance. You do one of these molecular tests. Molecular test is also favorable. It's one more piece of information that hopefully can be reassuring for you to go or stay on active surveillance. On the other hand, if you have favorable pathology and the molecular test comes back high, unfavorable, that's basically a red flag. There's kind of a disconnect between the pathology and the molecular. It doesn't always mean the molecular is right. I've seen it when it's wrong. And it doesn't always mean the pathology is right, but it does give you pause to say, can we do something further to try to say what's going on? And in my opinion, what you would do in that situation is prompt additional biopsies, maybe more frequent biopsies, maybe do another molecular test from a different company that looks at different parameters. But it again gives you additional information to make a decision. Now, one of the kind of most important aspects nowadays is active surveillance for Gleason score 3 + 4 = 7. Is it safe? When can we do it? As I mentioned earlier, more and more men are undergoing active surveillance for some 3 + 4 = 7s. Well, when at the onset of active surveillance, it just wasn't done. So are there subgroups of 3 + 4 = 7 who would be good candidates for active surveillance? And you try to look at all the parameters you have: the extent of cancer, the percent of Gleason pattern 4, the nature of the Gleason pattern 4, is that cribriform pattern versus a non-cribriform. And then even if it's cribriform, there's different types of cribriform. So let me break some of these down. So the National Comprehensive Network, which is a group that makes recommendations that many institutions follow in the United States, has used the term favorable intermediate risk. What they define as favorable intermediate risk is that it's a 3 + 4 = 7, grade group 2, less than half of the cores are positive, and then either the rectal exam is not that bad or your PSA is not that high, either one of them. Now, when you look at outcomes for men with intermediate risk on active surveillance, this is from the SEER database. It's basically looking at all, as we can see here, over 100,000 patients from different pathology reports. The strength of the SEER data is that it's huge numbers. The weakness is they're just getting data off of pathology reports. So it's not being reviewed by experts necessarily. It's just whatever pathologists were at different institutions, and whatever they reported, that's what the SEER uses. So there are, again, pluses and minuses of SEER data. What we look at is on the top is low-risk patients. So these are Gleason 6, grade group 1. And you see there's a red curve and a blue curve. And you can basically, hard to make out the red and blue because they're literally overlapping. And the reason they're overlapping is the blue is low risk on active surveillance, and the blue is low risk on treatment, and the red is low risk on active surveillance. So what we can see is that the red patients on active surveillance have the same exact prognosis as the patients who are being treated, all in support of doing active surveillance. When we come down to favorable intermediate risk, again, 3 + 4 = 7, not as much cancer, either not a bad rectal or not a bad PSA, you can see these curves diverge. And what we can see is that the active treatment now in blue does much better. These patients are progressing more. Their survival is actually decreasing with the favorable intermediate risk, out 5 years and greater. So if you look at just this, gives you pause about doing active surveillance for favorable intermediate risk. But can you try to find a group within the favorable intermediate risk group that's maybe better prognosis? So we looked at this, and if you look at low risk and very low risk, that's Gleason 6, and then they have radical prostatectomies. Back then, when I was at Hopkins, a lot of these men were still undergoing radical. We could see about 6% of them had bad pathology at radical, adverse pathology, that in retrospect, you say that's good the prostate came out. However, favorable intermediate risk, 25% of them have bad pathology. So if you were on active surveillance with favorable intermediate risk, 25% of those patients potentially have serious disease that you wouldn't want to be treating with active surveillance. Even if we try to take that favorable intermediate risk and say they only had 1 or 2 cores positive and not a lot of cores, cancer in core, still almost 20% had bad pathology or radical prostatectomy. Again, raising questions about doing active surveillance for favorable intermediate risk. You can argue, what if they had a multiparametric MRI guided biopsy? Maybe that would be better at finding the aggressive cancer and finding who's the best candidates for active surveillance. And this study showed that even if you had a favorable intermediate risk on a multiparametric MRI guided biopsy, there was a 12% chance of having bad pathology. So again, maybe you would have been undertreating 12%. Not as bad, but still, it's a risk. What hasn't been looked at as much is there a cutoff for percent Gleason pattern 4 to help identify which men with a 3 + 4 can undergo active surveillance. And even if you did come up with that, there's different ways for pathologists to calculate that. What is lacking is long-term follow-up studies looking at the percent pattern 4 with men in active surveillance. And that's what we really need. The other thing is the issue with cribriform glands. So the vast majority of studies on prostate cancer with cribriform architecture shows that these are basically a bad pattern 4. It's associated with aggressive outcomes. Molecularly, they're bad. And so if you had a 3 + 4 = 7 and there was cribriform glands, should that rule out active surveillance? Number one, a lot of pathologists do not report whether there's cribriform glands present or absent. They should, but they're currently not. But also, even if there are cribriform glands, the size of the cribriform glands can affect prognosis. Most of these studies on cribriform glands have shown that the larger cribriform glands are the ones with the worst prognosis. So on every report, when I see a 3 + 4 = 7 or a 4 + 3 = 7, even higher grade, I will report whether there's large cribriform glands present or absent. But again, that's not the case in many pathology reports. But as I emphasized, we do need longer follow-up studies, also with cribriform glands and large cribriform and small cribriform on active surveillance. What about other findings? Let's say you have cancer, Gleason 6, or maybe even a 3 + 4 = 7, and you're on active surveillance. Elsewhere in your biopsy, or maybe on your repeat biopsy, you'll see the word atypical or ASAP. Basically, ignore that. Once you have cancer, ASAP or atypical means nothing. Similarly, you may see on another core, or even on the same core that you have cancer, you might see the word high-grade prostatic intraepithelial neoplasia, HGPIN. It's confusing because when you see the word high-grade, you think that's horrible, something bad, because you think of high-grade cancer as bad. Turns out high-grade prostatic intraepithelial neoplasia means nothing once you have cancer. So despite the term high-grade, ignore it. if you're on active surveillance already with cancer. Now, as I mentioned, a finding that does affect active surveillance is intraductal cancer. Typically, as I noted before, it's often associated with high-grade invasive cancer. So let's say you have a Gleason 6, you're on active surveillance, but one of the biopsies shows intraductal cancer. That's telling you that probably elsewhere in your prostate, there's unsampled high-grade cancer, and consequently, you should not be undergoing active surveillance. So intraductal cancer typically is a contraindication for active surveillance. You may also see the term atypical intraductal proliferation, or AIP. Those are glands that have some features, but not all of intraductal cancer. So it's important, if you're on active surveillance and one of your biopsies show AIP, to talk to your urologist and say, can you find out from the pathologist, is this an AIP suspicious for intraductal cancer, or is it an AIP not suspicious for intraductal? Because there is a spectrum. If it's an AIP suspicious for intraductal cancer, and otherwise you have all the good criteria for active surveillance, what I would typically recommend is a repeat biopsy before undergoing active surveillance to try to see, is there in fact intraductal cancer somewhere, which again would then typically not be an indication for active surveillance. Briefly, I'm going to just mention a new grading system that came up with at the Cleveland Clinic system. You may hear of it. You may look into it. So just to be familiar with it more than anything else. What this new system comes up with is just general categories. So it's not numbers. You're not going to see Gleason, grades 1, 2, 3, 5, etc. They have basically unfavorable histology, favorable histology, and something in between. Unfavorable histology, some of them we've already talked about, like any Gleason pattern 5, that's the worst grade. That makes sense. Large cribriform glands, we've talked about, that's bad. Intraductal cancer, again, we've talked about that. I haven't talked about, there's an unusual type of prostate cancer called ductal adenocarcinoma. It's confusing because it is different than intraductal cancer, but that's uniformly agreed to being an aggressive cancer. So again, not a problem, including that as unfavorable histology. The next two are a little bit more controversial. Complex anastomosing cord-like growth is something that I kind of have a hard time knowing exactly what the authors of this grading system mean. So I question how reproducible that would be. Also, our studies show that if prostate cancer causes the normal stroma in the prostate to be very reactive to it, we call that stromogenic cancer, those are aggressive features as well. I also have questions, though, because most pathologists are not familiar with quantifying or saying how cancers react with a stroma, and given a grade 3 versus, let's say, 1 or 2, how reproducible that would be. So I have some concerns about this new grading system, how it would work in practice, even though I think there are some good points to it. I'm not sure it adds that much to doing our current system, and then noting that there's large cribriform glands or intraductal cancer or a lot of stromal reaction or ductal adenocarcinoma. So, currently I would note all those on a current report, so that would be in a current report regardless. But nonetheless, that's just something to be familiar with. And then what they call kind of in-between histology, between favorable and unfavorable, is small cribriform glands, something that's kind of another type of small cribriform glands, which is glomeruloid, and poorly formed glands. So basically, other types of Gleason pattern 4 they call in between, and then Gleason 6 would be favorable histology. The new grading system has only been shown to be predictive of prognosis after radical prostatectomy. So it needs more studies. You have to study it on biopsy. You have to study it with radiation therapy and other types of treatment. There's been no studies outside of the Cleveland Clinic to say how do other pathologists do with this grading system, how reproducible it is. So currently, other than I think in the Cleveland Clinic, maybe one other place, this is not a grading system that's out in practice. But again, it may be something that catches on. You may hear about it. So again, just a little bit to be familiar with it. I'm going to end with a little bit about artificial intelligence and prostate biopsies. So what is the good points, the promises of AI? It can avoid potentially undiagnosing small cancers. And that is because the AI is set for maximum sensitivity. Find anything that's abnormal on that biopsy. So if the AI looks at a biopsy and says, I don't see anything abnormal, that can reassure a pathologist that a case is benign. I think that's good. Again, another promise of AI potentially is better standardization of grading. Studies have shown it's equivalent to pathologists, but it has greater reproducibility. What it has not been shown is whether it's more accurate grading than, for example, experts. Another promise is now AI is starting to shift from diagnosing prostate cancer and grading to more prognosis. And I think that's probably the wave of the future for AI, because AI can capture things that the human eye can't. So it probably shouldn't just try to reproduce what a human does in grading and diagnosing, but look for things that we can't do. Look for subtle changes in the stroma, the nuclear features, spatial orientation. That, again, just too complex for the human brain and eye to do. And so I think in the future, AI will complement grading and clinical risk systems by adding these independent prognostic values, capture novel, potentially patient-specific morphological signals. Limitations, again, AI is trained, that's what it's supposed to do, to detect anything abnormal. So it's not going to be that specific. It's going to overcall a lot of things as cancer because it doesn't want to miss any cancers. The problem with AI is that there's also a lot of mimickers of prostate cancer that AI will probably call cancer. And some of these variants of prostate cancer are too unusual, and if they haven't been trained with AI, then AI is not going to recognize them. Also, it's important to recognize that every lab has a slightly different staining. When you cut them, there's all these artifacts, and the question is, can AI account for all this variability? There's a lot of costs to do AI equipment, and so a lot of labs do not have the ability to even do it if they wanted to. Also, all these AI software basically says, this is a test, you use it, but we're not liable for it. So you cannot sue the AI programmers if there's a diagnostic error. There's literally no responsibility. So ultimately, the reporting pathologist must be responsible for either accepting or rejecting the diagnosis proposed by AI. My concern is that some pathologists are going to rely so much on the AI, thinking, "Oh, this is AI; it's 100% accurate. It's amazing," and potentially there will be diagnostic errors. So in summary, I've shown you, hopefully, that there's a wealth of information that can be obtained from the biopsy report. The report is only as good as accuracy of the pathologist. Critical to have high quality pathologists to get the best diagnostic and prognostic information for you as patients. Thank you.
All right. I told you off camera before we started the Q&A. I've never seen you move so quickly through a slide set. So I'm going to use the chemical scientific name for it. I'm convinced you had a lot of 1,3,7-trimethylxanthine, which is also known as caffeine this morning. Am I correct?
Actually, I have internal caffeine. I don't drink that much coffee. I'm just normally kind of warp speed.
That's fabulous. All right. So what I want to tell the audience is that Dr. Epstein is everywhere. We all agree he's the Michael Jordan of our time, or LeBron James. We can all agree on that. But what we need to do is he's in a lot of different places. I want to try to break down my Q&A into 7 parts. And we're calling this Q&A a Master Pathology Review class. So notice how I gave you big wording like Doc J. Epstein. Remember Dr. J? You're like the other Dr. J. And then I put my name in small letters because I just wanted to show some humility there when I'm with the King of Pathology, or the Emperor of Pathology, or whatever you want to call it. All right, you ready for my first question?
Sure.
Let's see if I can throw you off in the first question. I did this for Dr. Kwan at the Mayo Clinic. He got it right, and I predicted he was going to get it wrong. Who played in the national championship college basketball game a few weeks ago? And what 2 teams? And do you know who won the national title in basketball this year, 2026?
1 second. Jeepers.
And remember, take your time. This is like Jeopardy, that song. I ask these questions because I'm convinced that some of the top people in cancer don't have time to watch TV or basketball, so they generally get these questions wrong. So it's always a deferential question.
I would say Yukon versus, and I know Yukon lost.
Yes, they
Um,
definitely lost to the
right,
greatest team ever.
right. And
That's your hint. The
yeah,
greatest college team ever assembled.
Michigan.
Exactly. All right, you win. I'm going to send you a hat along with the other gift I'm going to give you at the end. Wear it proudly, my friend. Wear it proudly. Okay, excellent. All right, what I'm going to do is something differently. Over the past 15 years, I think, as I've seen you and interviewed you, we always mention how to reach you at the end. I find that that doesn't work. For people have the most attention span at the beginning of the Q&A. So I'll go through this and you can interrupt me at any time or I'll ask you a question. And I know you didn't ask for this, but I think this is part of the value of the Q&A. You are at Advanced Uropathology of New York. There is the website. Monday through Friday, you can be reached. It's easy just to go to advanceduropathology.com if you're looking to do a second opinion, right? I think all that information is correct.
Yep, absolutely.
Okay. However, when you go on there, there's a form. And a lot of patients, as you know, want their own second opinion, but didn't necessarily hear from the doctor that the doctor wants a second opinion. So this form is a little bit, I mean, I don't want to say it's confusing. I just think for a patient who gets on there, what's the bottom line information if they want to be the impetus? They want to help drive the second opinion that gets to you. Can you just give us some basics of how they can do that? They're supposed to contact their doctor and the doctor's supposed to fill this out, this form out, or what are your thoughts there?
Yeah, so what I tell patients, the easiest thing is to email me. It's J Epstein, Jepstein,
Yeah.
at IMPPLLC.com. It's on the website also.
Okay.
If they email me, that's my work email, not my private email. If they
Yes.
email me at jepstein at IMPPLLC.com, I reply back with the forms, but also an instruction how to fill out the forms.
Oh, it is there on the website. Okay. So you want them to email you, and I'm going to talk to the team, and they can hear me loudly that and when this goes live, we want them to throw that email on there, and you are going to regret it because you're going to get tons of emails now, and you're going to say, why did I give out that email so
It's
easily?
okay. What I find out is ultimately I want to make it easy for patients, number one. Number
Yes.
two, I don't want things to fall through the cracks. And I found that at least if they have my contact information with my email, if there's a problem, if something doesn't work on their end, they can reach back to me and I can try to straighten it out.
Okay. Now I'm going to run through the rest of this kind of topic, and bear with me. Does someone ever send you? I mean, let's just set it up this way. Have you ever even estimated the number of pathology slides or the number of cases you've gone through in the terms of the thousands? Have you ever even tried to ballpark it? It's got to be the most in the world, but are we talking in your career thus far? Because you still have a long way to go. That was a compliment. And then we talking over 15,000, 20,000, 10,000?
And for hundred thousands.
Hundreds of thousands.
Yeah.
So this is why we call them the LeBron James or the women's hockey team or what USA women's hockey team, whatnot. Hundreds of thousands. You ever get a biopsy or samples from someone that had it done years ago? So let's say 5, 6 years ago. I understand it's most often used in the immediate time. Okay, you got a biopsy or you got surgical pathology, you get it sent as a second opinion. But do you ever get someone that's 3 or 4 years ago got a biopsy, maybe active surveillance 3 or 4 years ago, and they just want to know whether that original biopsy from many years ago is what it is?
Yep, absolutely. As you said, it's not as frequent,
Yeah.
but those slides are there. They never go anywhere, so it's possible to do it.
One of the greatest fears in the second opinion process or first opinion process, because when I say second opinion, let's say you're the first opinion, sometimes the first opinion is good enough, right? I mean, sometimes if you were to get the first opinion, you wouldn't be called a second opinion, but sometimes the first opinion is good enough when you go to a world-renowned expert. Anyway, one of the biggest fears I see on the internet today is someone's worried that their samples going to you is not actually them, that it might have been misclassified. I don't know how bad a problem this really is, but it made me think of this in our introductory series of questions. Do you recommend that patients ask or pay for what's called DNA-based verification of their slides? So the slides they're seeing or you're seeing are clearly that person that has been matched up, say, with a buccal swab. So, I've seen some of your reports. You have some DNA-based verification that's done, or some people have done. Is that something you recommend, or you're not sure yet, to match the patient up with their actual slides? What are your thoughts on that?
It happens extremely rarely that there's a swap in the specimen. So it's kind of a mixed bag when you're deciding. Number one, it's rare,
Yeah,
extremely rare. But number one, when it does happen, it's obviously can be devastating.
yeah,
So if it were me getting a biopsy, I'd probably do it, but it's
interesting.
hard to recommend for everybody to do it because it is so rare.
I wonder if that's covered by insurance, though, if someone wants to get it done.
That
But
I
I
don't know.
guess it
Yeah.
depends. Okay, now we go further on. See, this is how we're going to go further into here's my thought, and then I want you to comment on why, before I talk to you, I actually feel this way after 35 years. Moyad says second opinions of pathology should be the rule now often and not the exception. Okay? This is my conclusion for the audience. I think it should be the rule, not the exception, and I'm going to tell you why and tell me if I'm wrong or right in any of these. Why I think the second opinion is so important. Can we admit that when you look at Gleason grade, this is reason number one. When you look at Gleason grading or any of these variants you've been talking about in your lecture, we're still talking about this is based on not a computer. It's based on morphology. In other words, AKA, it's based on subjectivity. It's based on the experience of the person reading the slides. So these critical markers and variance that you're talking about is still based on humans. And you're giving so much power to a opinion that it's almost scary. So do you want to comment on that number one reason why I feel so strongly about second opinions?
Yeah. Yep, I totally agree. But the main thing is also you don't know who's reading your slides. Even if
Yes.
it's like a top act, you might think, oh, it's going to Mayo Clinic, Cleveland Clinic, Mass General. I'm just naming, Hopkins, whatever.
Yeah.
But in those places, there are some very good pathologists, and
That's
there are
right.
some that are not as experts or not as good. Somebody could have been just out of their training. You have no idea.
You have no idea. I've told some friends recently to get their pathology report, see who the pathologist was, and if the pathologist says, I'm the master of all trades, I'm a general pathologist, I look at all types, I tell them to be a little bit more nervous about that. If you see a uropathologist, someone with experience, maybe less nervous, but that is a really good point. Now, we also know Gleason and everything you talked about is a primary predictor of current and future treatments. Now, second opinions, yes or no, insurance often covers it.
I would say almost all the time it does.
Almost all the time, making my point three stronger than ever. Turnaround time on a second opinion, let's just say in your case, this is not something you wait for 4 months on. It's usually fast. How fast is the turnaround time on average, for example, when you do it?
With me, once I get the slide, 24 to 48 hours, typically less than 24 hours. The rate limiting factor is the outside institution getting the slides to me. Sometimes they're quick when you ask them to do it. Sometimes it's like pulling teeth.
And for those people who are pulling teeth and it's taking time, don't you agree? I'm trying to help you be PC here. Don't you agree that it's okay for the patient to nudge that recalcitrant institution a little bit and say, can you get my slides there, please, by FedEx? I think it's okay for patients to call and say, what's the status of my slides getting over to Epstein or somebody else? Don't you agree that they should be involved?
100%. Those slides belong to you. It's your on the line. Your treatment diagnosis is on the line.
Yes.
Some places will try to, have the kind of almost egotistical opinion. Well, why are you asking for a second opinion from our place? We're like such and such place. We don't, we're good. And the answer is, that's your choice. You want a second opinion, you ask for it, and you might have to bug them or have your urologist bug them.
That's right. Okay, I'm 4 for 4 with you. The fifth reason I think everybody should at least consider this. And keep in mind, I have no association with Dr. Epstein. I'm not involved with him. There's any of these companies in pathology. This is the reason, the conclusion I came to after 35 years. I have found there's a POM with a second opinion or a really good first opinion. POM meaning peace of mind now and later. You know that you did it. And part of that peace of mind is something people don't realize. When it comes to you, and I know some other pathologists that do this too, if patients want to talk to you by phone and understand their results, and you kind of give your thought about the results, why they are what they are, and some of your thoughts, you do that, right? You get on the phone and you talk to patients also. You're a pathologist that actually interacts with the patient. Is that right?
Absolutely. If any patient wants to, I have a long commute on the way home, so that's like the perfect time. I don't rush them. We can have a nice talk about it.
And how much more does that cost for the phone call?
Nothing. That's just, I do it as part of my consult.
How'd you like that softball question? That's my fifth reason. I give 5 strong reasons. Peace of mind, and you actually you can have a discussion with the pathologist. There was another friend of mine the other day who was another pathologist in the Midwest. I said, call him. Maybe he'll talk to you, walk you through it. He called him and walked him through it. He felt so much better. So for those reasons alone, people should always consider a really good first opinion, Dr. Epstein or another world-renowned expert. All right, here's a question I've never seen anyone ask you in all the conferences I've ever attended, okay? And maybe they have, but it's better if you tell the audience what your thought is on this. What type of second opinions do prostate pathologists do, including you? See, everyone just talks about prostate biopsies, right? Or surgical pathology after a radical prostatectomy. But what about if you have lymph node dissection? What about a prostate biopsy after radiation? We're going to talk more about the biopsies and things after treatment, but can you just walk us through what kind of second opinions you do on what kinds of tissues? Is it everything head to toe or that might have cancer or prostate cancer? How do you even tell somebody the range of biopsies that you look at?
Yeah. So number one, I was a general surgical pathologist also for decades, so I have that experience as well. So I will look at biopsies, radicals, TURs, open prostatectomies, lymph nodes, bone specimens, lungs, if there's, and not just prostate. Obviously, I do, even though we're talking prostate today, but bladder, kidney, testis, penis, scrotum, etc.
Yeah. So even after BPH procedures like transurethral resection, you mentioned TURs, you'll take a look at those and see if some of that tissue has cancer in it.
Yeah, absolutely. Yep.
See, I think sometimes the broad brush is painted that, hey, Dr. Epstein just looks at these biopsies that come from the prostate, not realizing that all around the world, people take biopsies of tissue all over the place looking for prostate cancer. Some you can agree with or not, but you look at all those.
Yep, that's a good point. Yep. First time I asked that question. You're right.
Holy mackerel, made my day. See, maybe I'll send you 2 Michigan hats. So that'll be good. Your family can share on it. What do you think of this? Should a patient keep a copy of their final pathology report their entire life? Do you think this should be like taxes taxes, they say 7 years, but records for 7 years. But is this one of those things in your medical record that's so critical you should just put it somewhere in a filing cabinet the rest of your life?
I would. Yeah, absolutely. Yeah. Or have access to it online or however, but yeah, you should.
I've never heard you answer that. All right, now I'm going to give you some quotations as we finish part 1, and then we go into part 2. These are the largest parts, and then the rest of the parts are easy. But then again, we've only been going 20, 25 minutes. We're going through these much faster. Here are some quotations, and if they weren't assigned to you, please let me know. That always stuck in my head, and I made posters of them. First one is you said correct grade is critical and the foundation for the optimal treatment of prostate cancer, right? You said that.
Absolutely.
Okay. Then you said
But like you
25.
could have the best surgeon in the world, the best radiation oncologist, but if you have the wrong diagnosis, the wrong grade, you'll get the wrong treatment.
Touche. 20. This is what you also said. 25% of Gleason 6 on biopsy are Gleason 7 or higher due to sampling error. Is that
Yeah,
still true?
it might be 20%, 18%. It's still ballpark significant.
Okay. So all of this was making me think, why don't I just ask Dr. Epstein the bottom line question? And I'm not asking you to be specific and I'm not asking for references. I'm asking for ballpark because it always almost makes me fall off my chair. In your opinion, what percentage of pathology second opinions, let's just say with you, I don't, or you just ballpark, are upgraded, downgraded, and no change? So when you get a biopsy or you get some kind of tissue, what percentage of those second opinions are, do you upgrade, do you downgrade, Gleason is less, or do you not even change at all? Do you ever think about that?
Yeah, I would say overall about 30% of the time I would change the grade, and it's almost equally upgrade and downgrade, 15% each, and then maybe 70% no change.
Wow. Okay. So almost one third of the time,
Right.
but equal in terms of downgrade and upgrade.
Yeah, it depends a lot on the pathologist. Like I know there are certain pathologists that I consistently get specimens from, like the clinicians ask me to look, that they consistently, downgrade it. They'll call everything a 6 and it might be everything is 7 or vice versa. Yeah.
Yeah. Have you ever, I'm sure the answer's got to be yes. Have you ever received a sample that said cancer and actually when you looked at it, you didn't see cancer?
That happens uncommonly, but it happens enough that yes, and that's one of the reasons why. Again, if I were ever diagnosed with cancer out there, I'd want a second opinion. Just number one, make sure I have cancer.
So it happens enough that someone's told they have cancer and then that must be the oddest moment of your career. I mean, it must be the most joyful, but you're saying, then I can't even imagine that note that comes back that goes, I don't see cancer here. And does that happen every year? Once a year?
I would say once a year at least. Absolutely. Yep.
Holy mackerel. What about vice versa, as we say? What about you see a sample that came into you? Because I've always argued that when someone sends their samples to you, they need to send all of their samples, not just the ones with cancer. They seem to send the ones that don't have cancer because they're having the guru look completely across the board. Why not just send all the samples? You might not like that I'm saying that, but I think if I'm going to have you do my second opinion, I want you to see the samples that say benign tissue, not just the ones that say cancer, right? Okay, let's think vice versa. Have you ever seen a benign? This came in as a sample that said no cancer. And then when you looked at it, you said, well, wait a second, that's actually cancer.
What I see very not infrequently is a specimen that's sent in with cancer. That's why they're asking me to look at it. And
Yes.
some of the benign parts have cancer that was missed. What that leads me to believe is there are plenty of benign specimens out there that cancers were missed. Those don't get sent to me because if somebody gets a benign biopsy, usually they just don't send those to me.
Yes, which goes back to the Moyad point of send everything. And you're saying that maybe it's once in a blue moon, but you have seen situations where you've looked at something that's supposed to be benign and actually it's cancerous.
Right.
Yes?
Yep, no question.
Man, Dr. Epstein, you are making me look incredible today, not just you. All right. Another paper. I'm not even going to go through it. Just another paper I'm inundated with by saying how good MRI is at picking up aggressive pathology. So after the MRI says this is PIRADS 5 or whatnot, it seems to be doing a good job of picking up aggressive pathology after you look at it in its biopsy. Do you have any comment on that? I mean, that makes me feel good, but we're getting a ton of these papers lately.
Yeah. So I see every day a large number of, MRI guided biopsies where they'll have their routine and then they'll say target area. 80% of the time, 85% of the time, the target area has the worst cancer, but then 15 to 20% of the time, the target might miss the cancer totally, or it misses the worst cancer. So it's not foolproof by any stretch, and that's why you do the systematic biopsies in addition to target. MRI has been a game changer, no question, but like I've heard some people say, why don't we just do the MRI guided biopsies only, just do the targeted areas? And
Exactly.
15-20% you're going to miss the worst cancer or cancer in general.
15 to 20% is not insignificant. Interesting. How did you feel about part one Q&A? You ready to go to part two?
Yeah, go for it.
Okay, this is the largest part, and the other parts are much smaller. So bear with me as I decide how much we're actually going to go through. I call part two Gleason scores, amount of 4, and aggressive variance with Dr. Epstein, and then my name is much smaller. Okay, so we're going to go through part two now. Can a Gleason 6 turn into a 7? Vice versa. This is just a basic question. Can a Gleason 6 itself change or turn into something more aggressive? Or if done correctly, does the Gleason stay the same throughout your whole life?
So there's no way for us to 100% know. What I would say is the vast majority of cases, the Gleason 6 stays the same. We do see some cases where somebody's had a Gleason 6, 6, 6, and then all of a sudden there's an 8, like 5 years later, 8 years later. We have no idea whether that 6 turned into an 8 or that 8 was there, or it's a new cancer or a new 8. So we can't be sure, but what I think is reassuring for patients, the vast majority of the time, that 6 stays a 6.
Would you say that's the case also on a relapse and recurrence? That let's say a 6 or a 7, and then it comes back after radiation or after primary therapy. Is it often that the morphology is similar upon recurrence, or you can't say that as a generality? It could be very different Gleason-wise.
Yeah, it's hard to say. A lot of times occurrences are higher grade, but that could also just be sampling as well.
Interesting. See, I wish I would have asked you this years ago. Here's a quote that you said that I wrote down. You said Gleason 7 is not homogeneous. 4 plus 3 equals 7 has a much worse prognosis than 3 plus 4 equals 7. Do you remember saying that?
Yep, absolutely.
Okay. So this brings me now to the part of the Q&A that I'm going to try not to get stuck in the mud, because people get stuck in the mud here. This gets a little sticky. I've been watching a lot of lectures from pathologists talking about the amount of pattern 4 in the biopsy, and you've talked about this. The amount of pattern 4 is one of the greatest predictors of recurrence and distant metastatic disease, right? The amount.
Right.
And you agree with that. You've mentioned it. And they've even in studies put the amount or the volume of Gleason pattern 4 up against risk scores and other algorithms and things, and it still is one of the strongest predictors. Okay, so the amount, knowing the amount is a game changer, but can you again summarize, how do you report the amount? Do you report the total amount of Gleason 4? Do you say 20%, 30%, or are we supposed to assume that the amount is reflective in the primary and secondary grade? So if the 4 comes first, there's obviously more than 50% there. How do we put our hands around this amount of 4 and why I should be so consumed by it?
Right. So as I kind of went through the talk, you get a rough idea of the amount with the grades. 4 plus 3, it's over 50%. 3 plus 4, it's under 50%. But that's it. That's all you know. You don't know with the 3 plus 4 if it's 1% or almost 50. With the 4 plus 3, you don't know if it's 55% pattern 4 or 90% pattern 4.
Exactly.
And so that's why every time I say 3 plus 4, I would put in parentheses, 5 plus 5% pattern 4. Or if it's a 4 plus 3, I'll say parentheses 90% pattern 4, which is pretty much, a smart patient told me, yeah, that means I'm close to a 4 plus 4. And I say, yep, you're right. So now I do it for every part. I don't at the end of the case try to do some grand summary because one of the things I don't know as a pathologist, there could be 2 different lesions. I don't have the MRI with me. So I don't know. I don't want to be adding 2 different lesions together potentially incorrectly. So I just give each part what that is, percent pattern 4.
When you say you don't have the MRI with you, but do they send you the MRI report also at times?
No, typically not.
Why not?
Don't know.
Don't know as in I wish they would, or don't know as it doesn't really matter. I am who I am.
It probably wouldn't make a significant difference how I'm reporting it at this point.
Wow. Okay. then why do I see people talk about the amount of four? You can still be an active surveillance candidate if it's less than 5%. Then I saw another paper that said less than 10%. And now I'm seeing some papers that say, oh no, 20% is the cutoff. If it's less than four, is 20% or less your active surveillance. How am I supposed to even put my head around it? Is it less than 5, 10, 20? What is this?
And the reason is, which is what I said, we don't have studies. So the problem is you need 10 years follow-up of men on active surveillance, at least, with all these percent pattern fours. And we've only started putting in percent pattern four in the last 3 or 4 years. So we don't have data. So I think people are comfortable with the 5 to 10%. Less than that's pretty good.
Okay.
20% is like, maybe it's good, but we have no data. But some people say, well, let's try 20, but it's guesswork at this point. The 5 to 10% is low, so you can kind of feel a little bit better with that. But again,
yes. So single digits is more subjective. It feels good, but once you go into double digits, it might be worse, but we don't know.
We don't know. Yep.
Wow, man, you put the canned in candid. That's excellent. I appreciate that. Then I've also been reading there are different types of four. Now we're going to start moving on into the variants. This is the toughest part for me, but as someone who wanted to go into pathology and then I suddenly didn't, and I should have done it. I loved pathology so much. But this is what I need you to define. There's different types of Gleason pattern 4. And you mentioned 3 of them, but 4 come up often in the literature. So can you tell me, there's cribriform, right? That's the one that you talked about. That's the most aggressive. That's the worst of the types that can come up. There's poorly formed glands, fused glands, and glomeruloid, which is like kidney-like, I guess. That might be the best. So am I just looking for this one really as just or what, do you have anything to say about it?
So what I would say is having no 4 is better than any 4. But if you have 4, the poorly formed, fused, and glomeruloid are probably the least aggressive of the pattern 4s. And there are some studies suggesting that if you have only those types, in some cases, it behaves like a 6, like as if you didn't have any 4. So I think those studies are remain to be done with long-term follow-up, et cetera. That's one of that whole, what I alluded to at the end with that unfavorable, favorable grading system. Yes. So in that system, the poorly formed, fused, and glomerular would kind of be intermediate risk in a sense, whereas cribriform would be unfavorable risk. But then again, there's different types of cribriform. There's kind of worse cribriform and not as bad cribriform too. So it is confusing. Cribriform is definitely something that's bad. Large cribriform, definitively bad. No question about it.
So these 3, I don't have to be as nervous about. This one is the one that's far more concerning in terms of its aggressive component. And then we'll talk a little bit more about that in a second. That's right?
Correct.
These three just sound.
Also, if I had, let's say, a 3 + 4 = 7, no cribriform, 5 to 10%, 10%, Gleason pattern 4, I would tell a patient, yeah, you're still a good candidate for active surveillance. You still have to be watched carefully, but I wouldn't tell them, not to do active surveillance.
So if they had 5 or 10% and they had glomeruloid or fused or poorly formed, you would feel more comfortable with that on active surveillance.
Correct. Yep.
Cribriform, such an interesting word. I brought it up first. I think 6-7 years ago when we did an interview, I had to get my hands around it. It was kind of a newer term, but in Latin, cribrum, it actually means, and you're talking about a lot, means sieve or hole-like. So I just thought, I don't know, I'm sure you were a nerd in school like I was. I thought sieve, here, this is my wife's sieve. She let me borrow it. It's a very large sieve. Why was cribriform named sieve-like? Why does this remind me of a kitchen utensil?
Right. So if you were to zoom in on that sieve, it's basically something with little holes in it, little punched out holes in it.
Yes.
And so that's what it ends up being. I like the analogy of Swiss cheese in a sense, because that's what it kind of looks like. It's a solid sheet with like somebody took little things and punched out little holes in it. Here, they're tiny little holes. It doesn't quite look like that, but yeah.
I'm just trying to show you the dedication that I have, toward being a moderator.
Or colander, think of it like that, exactly.
Yeah, noodles. I mean, truthfully, sieve, Swiss cheese, I could have brought Swiss cheese, but then my wife would be upset if I use that. But The reality is that I don't know if you remember, Civ is the name we use for hockey goalies when you score a lot of points on them.
Okay.
Remember that? They would throw sieves on the
Yep.
ice. Okay, so Civ. So is it fair to say if you have cribiform exists and so you have Gleason pattern 4, let me ask you this. Can you have cribiform on a Gleason 3, a pattern 3, or does this only exist on 4 and above?
Only on 4 and above.
Okay, so if some pathologist said you are a GG1, you're a 3+3, and you have cribiform, something's not right there.
100% wrong. Yep.
Interesting. So if you have cribiform, and let's go through this again. You're not necessarily a good candidate for active surveillance if you have large cribiform versus small, or is that just, I'm simplifying that too much?
Yeah. So large cribiform, 100%, I would recommend not active surveillance. Small cribiform, I would say we're not sure.
Well, but who decides large versus small? Because you showed the Cleveland Clinic new guidelines and they say it's 0.25 greater than 0.25 millimeters or something. I'm like, well, who decided that cutoff? Did you decide that cutoff of large versus small?
So there have been several studies with different definitions, and several studies have used the 0.25 millimeter definition to show its prognostic. So that
Yeah.
is the definition I use as well. It is objective. And so there are other ones, other criteria there that are not objective. So I think it's as good as criteria as we have.
Okay. Wow, that's really interesting. All right, we're moving through the largest part. All right. Now here comes the other dangerous word. What about if you have what if you have intraductal carcinoma of the prostate, IDCP? Does that eliminates you as an active surveillance candidate? Is that right?
100%. Yep.
Where would I see intraductal carcinoma of the prostate? I wouldn't see that on I wouldn't see that on 3+3. I'm only seeing that in 4 and above, right? When a 4 is involved or not.
Vast majority of times, but you can see a Gleason 6 with the IDC uncommonly. But the same thing with grading subjectivity. I just had a case last week where somebody had Gleason 6 and
Yeah.
it was called intraductal cancer with the Gleason 6. The clinician had the biopsy sent to me and it wasn't intraductal cancer. It was just high grade pain, which is nothing. And so, all of a sudden that patient went from an aggressive report, no active surveillance, to you're a good candidate for active surveillance.
That's why you proved the Moyad 5 that everybody should consider a second reading or get a really good first reading, because I've been reading in pathology lately that a number of pathologists, I'm not saying what the number is or the percentage, they're confusing high-grade PIN with intraductal carcinoma of the prostate. Is that right?
Yeah, so just like there's subjectivity with grading,
Yeah.
there's a lot of subjectivity with diagnosing intraductal cancer, either overgrading, overcalling it, or undercalling it.
Here we go. We're about to get really into the mud of intraductal carcinoma of the prostate. I don't think that gets enough love or attention. So if you have intraductal carcinoma of the prostate, because you can have intraductal carcinoma and or cribiform, correct?
Correct.
People are always mashing them together, and that's incorrect. These can be separate. These can be separate entities, right?
Yep, absolutely.
Okay. If I have intraductal carcinoma of the prostate, which should be its own lecture, do you think I should get a BRC or germline genetic test?
I think it's reasonable. We do that reflexively. Yes.
You do?
Yes. I would say we make the recommendation to the clinician that they should consider it. Correct.
And is it true as the grade gets higher? I've seen some of these studies now and some of the retrospective looks. As the grade gets higher, as the Gleason becomes more aggressive, as you go from GG2 to 3 to 4, the chances of being diagnosed with intraductal moves up.
Oh, absolutely.
It increases. Okay.
Yep.
Okay. You said a BRCA2 on an intraductal? Oh man, am I going to be using that? Now it gets even more interesting with intraductal carcinoma of the prostate. It's not the same as ductal. If someone says you have ductal adenocarcinoma, it's not the same, right?
Right. Very, very confusing terminology, but not the same. Correct.
Completely confusing. Here were the points I've taken from your lecture and other lectures. You just said that it's often associated with high-grade disease, right? It's
Right.
It's an independent prognostic factor. Is that true?
Correct.
You said that you should probably BRCA test or do a germline test. They're not an active surveillance candidate, but here's the thing that doesn't get enough attention. these have been less responsive on certain types of treatment too, right?
Correct. Correct.
There is a concern about intraductal carcinoma being less responsive. Tell me where I'm going too far with this. There's been some, I know there's a mixed bag. There's been some to suggest it's less responsive to ADT, to chemo, and to certain types of radiation. And you said that in your lecture. You said that some of the radiation oncologists want to step it up, maybe
Right.
provide a boost to the area if they see, if you mentioned intraductal carcinoma of the prostate. What part of that did I not get right? Is that
No, I
right?
think you're 100% right. I mean, it is less responsive to our hormone therapy. Um, I think it's relatively less responsive to radiation, and that's why they again boosting up the doses in those patients. But then
Yeah.
there have been some studies saying that patients do better with radiation in those boost up doses than surgery. So it's hard to say. But I think what you can say is because it's more aggressive, it may be treated differently. Again, there's a lot of variability amongst radiation oncologists to how they, individualize therapy. But my old philosophy is always give them the most information possible so that they can make, the best decision. So that's why I always want to separate out whether there's intraductal versus just cribriform pattern 4.
And the new guidelines say the intraductal has to be mentioned in cancer grading, right? It has to be,
Should be.
it
Yep.
should be.
But it's not so easy sometimes to tell unless you do sometimes special stains. And some places just don't do that.
I'm seeing very large case studies. This one just came out in European Urology from some friends of mine where they looked and they saw intraductal and they were clearly much higher chance of getting recurrence or having metastatic disease. So they were suggesting that you need to hit them from multiple pathways. You got to do multiple treatments when you're dealing with intraductal. This is really a topic to me that's kind of taking off that I didn't think much about. Can you explain this one more time? I'm so glad I made a sign of it. Intraductal carcinoma of the prostate. You're saying AIP is another marker suspicious for IDC for intraductal carcinoma of the prostate. Can you just once more repeat this?
Right.
This is making my head spin.
Right. So the term AIP covers a wide range of lesions. Some of them not that close to intraductal, but worse than PIN, and some that are basically intraductal, but just don't quite fit the criteria exactly. It's that latter group where you want to get a repeat biopsy because there probably is full-blown intraductal somewhere else.
Yeah.
But there are other AIPs that are not that worrisome. And so that's kind of why, if you're diagnosed with AIP, you want to get some indication from the pathologist where on that spectrum. So what I do, if it's AIP suspicious for intraductal, I will put that in there, saying AIP suspicious for intraductal carcinoma.
Okay. Okay. Great. Last one in this, and then we move to the other four parts really rapidly. We're 45 minutes in. I feel like we're doing well. Feel free to take a sip anytime. I know these are some curveballs you've never been thrown, but that makes it fun. What did Gleason pattern 5? You said 50%. Was this a different lecture? 50% of the time, outside pathologists did not call it, first of all, and no gland formation. We know what a 5 is based on your setup, but can you repeat that again? That people don't like a Gleason pattern 5. People don't like to call it a 5. Why would that be? Because you're just making too strong a statement and having too much confidence in your reading. Can you explain that?
Yeah, in my opinion, I've never asked pathologists, but there is a fact that in my experience that pathologists undercall pattern 5 significantly. And the
Yeah.
only reason I can come up with is they're just hesitant to give the patient that worst diagnosis possible. They figure to just back off a little bit.
Okay, but if I give it a 9, you're saying 9 and 10 are now in
9
the
and 10 the same.
same
Yep. 9
grouping.
and 10 are the
Same
same.
grouping.
Yep.
All right, you ready for part 3? Here's another term I've not seen in pathology in lectures. I haven't, and I'm taking it on as a pseudo pathology guy. I'm seeing incredible importance on this, but I'm not seeing the importance out there. Part 3 is called LVI, I call it another aggressive but unsung pathology feature, LVI in our master class. Let's talk about LVI because they are on pathology reports. It is called lymphovascular invasion on biopsy. Okay. Maybe you want to kind of just explain what lymphovascular invasion on biopsy is because you see them on pathology reports. And let's just say you have that. The European urologists are now saying you're not a candidate for active surveillance. Okay. So
Right.
that's a two-part question. What is lymphovascular invasion? And why are the Europeans now saying, urologists saying in guidelines, you're not a good active surveillance candidate? Why aren't we hearing more about LVI?
So we have little blood vessels throughout our body, and some of those are lymphatic, some of those are small little capillaries. One of the ways that cancer spreads, let's say going to the bone, going to the lung, liver, brain, etc., is when the tumor breaks into those little vascular spaces, and then they can go anywhere in the body, just follow the blood and set up shop somewhere else, which we call metastatic disease. Prostate cancer, when we see lymphovascular invasion, it's almost always with high-grade disease, like Gleason 8, 9, 10s.
Okay.
You never see it with 6. I would say almost never see it with a 7, even a 4+3. So it's important to note it when you see it, but typically you're already in that setting, have bad disease with other parameters like grade. So yes, it would rule out active surveillance, but you're already ruling out active surveillance because you have high-grade disease. So you're not going to see a 6 with LVI, for example.
Okay. But you know, they're mentioned on pathology reports. They're not skipped. So I think people should know what it is.
Yep, no,
Right?
absolutely. Yep.
And so one of my, I call them friends. I got a million friends out there. One of the surgeons who's done the most radicals in the history of prostate cancer is Vip Patel. He's in Florida, and he's got a good database. And he just published a paper with over 10,000 men, 10,000 radicals, and they found that the combination of LVI and PNI, perineural invasion, which we could talk about in a minute. Anyway, it was an independent predictor of biochemical recurrence following complete resection. And I just thought, you know, that's a huge database. So am I making too much of this LVI, or is this going to be a big deal in the future?
Again, in radical, different than biopsies. So it's hard to say. But again, what I like to look at that paper, again, those cases of LVI probably were, again, relatively higher grade cancer.
Yeah. But you know, then they threw their magical statistics in there and found out that it was an independent predictor. So, you know, it's interesting.
So the only thing I would say about independent predictor, you have to be careful because it could be, let's say grade gives you 95% prediction, LVI gives you 96 prediction, so the grade falls away, but ultimately how much more did the LVI give versus grade? It may not be a lot, for example.
Yeah.
So you have to get into the weeds to find
That's
out.
a good point. It's like relative reduction in epidemiology versus absolute risk reduction, right? Sometimes the reduction or the impact truly clinically could be clinically trivial, not clinically significant. Right. Good point. We're already into part 4. That was part 3. Part 4 is you write about this, and I love when you talk about it, but can we talk about it? I only have a couple of things to say. I call it TRE, treatment-related effects in Gleason. That's our part 4, treatment-related effects. And here's what I've learned from you through the years, and tell me where we are. That depending on the treatment that you got, if there's going to be another biopsy or another reading by you, whether it's ADT or the second generation anti-androgens, chemo, focals, radiation therapy, in some cases, the pathologist is saying, hey, you don't grade those. So what does that mean? You don't grade them. You just say that you believe there's cancer there or not. And then they say in some cases like focal, you can grade them. And can you put your hands around this, your head around this? Because this kind of makes my head spin.
So some types of therapy, the cryo and the HIFU, basically just cause the cancer to die. It's basically mechanical. It's not really doing anything to the cancer in terms of altering the cancer. It's just hitting it with a hammer and killing it. Okay. And so if you see cancer in somebody with cryo or HIFU, it just means a hammer hasn't killed those cancers. But the cancer that's still there looks just like regular old cancer. You can grade those. Radiation and hormone therapy, after radiation and hormone therapy, some cancers don't respond that well to hormone or radiation, and the cancer could look just like regular cancer, meaning if I didn't have that history of radiation or hormone, I would never have guessed it. Those cancers I do grade, even if there's a history of hormone or radiation. If I see cancer, but under the microscope, it looks like it's unaffected, just regular old prostate cancer, you give it a grade. But Sometimes hormone and radiation can alter the cancer. And in those settings, you don't grade them. You just say this cancer with radiation effect or cancer
Uh,
with hormone therapy effect. And the reason why we don't grade them is that radiation or the hormone therapy can make the cancer look like a Gleason pattern 4, can make it look aggressive. But in fact, those cancers have responded well to therapy and they're just quiescent. They're just kind of sitting there, not growing. So if we were to grade it, it would give a very misleading grade that these are aggressive cancers, when in fact, what we should be saying is this cancer's, doing well. It's responded to the hormone therapy, the radiation, and that's why it looks funny, basically.
yeah. So it really depends on the individual situation.
Yeah, absolutely. Yep. So
Wow.
not all treated cancers you treat the same in a sense pathologically, right?
Well, we still know that finasteride and dutasteride for BPH, but not just BPH. All the attention of these 5-alpha reductase inhibitors come with large prostates and BPH, and those drugs come with some controversy. But you can't ignore the fact that a lot of men today are on Propecia or 1 milligram finasteride for hair loss. But the bottom line is a lot of people take this drug or another drug. What's the impact on you reading a sample or a prostate cancer pathology if someone's been taking that drug for a short or long time? Because
Yeah,
it's
so
hormone therapy. It's kind of a hormone therapy, you got to admit.
yeah. Most of the time, it does not affect what we see under the microscope, but then occasionally I'll see a case that say, I'll look at it, I don't have any history, and say, wow, that's pronounced hormone therapy effect. I contact the clinician and they say it's not on ADT or anything, but he is on, finasteride or Propecia. And then there are some patients who just have low testosterone, not due to drugs. And the cancer can look different and can alter it. So I think what we don't necessarily always think about is that each patient is unique and patients can respond differently and their body and their cancers can respond differently to the same drug.
Right.
Some patients just may be more sensitive to finasteride than another, or the cancer is more sensitive. And again, those can look different than somebody else who's taking the drug and doesn't affect their cancer at all.
But you should know the pathologist should know if they're on any of
Right.
these meds.
Yeah. In the past, I would say 99% of the time, we don't get that history. So I would say that the pathologist has to be aware and always on the lookout. Is what they're seeing just the cancer biology, or is what we're seeing potentially due to treatment effect? And they do look different. But again, you need experience because you're not going to get that history 90% of the time.
But what if you're a pathologist that hasn't seen many prostate samples of men taking finasteride for hair loss and or BPH?
Yeah,
Are they
probably.
supposed to know that?
They probably are not. Most pathologists don't have experience looking at cancer or radiated treated cancers either, or hormone treated cancers. So, and they're probably going to overgrade them because they do look higher grade.
Oh man. Well, in about 10 minutes, we'll be at an hour, 5 minutes. So I'm going to move through the last three parts. So it's not very long. This is part 5. I call part 5 MIM Ops, miscellaneous important Moyad path stuff. That's what I call it. It's going to be a new acronym that's going to sweep the country. I'm doing part 5 just so Epstein fans will say that Moyad covered it. And I'm just trying to get your pithy, it can be a quick answer or not, but I'm also interested in these answers. And the first one's a little daunting. The first slide I have, or the first picture, and the rest of them are pretty simple. But let's just go through miscellaneous past stuff people inundate us with. Any comment on location of the tumor, anterior versus posterior tumors when you're looking at them?
No, I mean, it's been shown they behave the same. It's just a matter of detection.
How about apex versus base? People don't realize in the prostate, maybe you can tell me, why did they name the apex the bottom of the prostate
No
and the
idea.
base the top? The base is supposed to be at the bottom and the apex is supposed to be the top, and in the prostate, the apex is the bottom. But anyway, that's a whole other problem I have with the naming. Any comment on apex versus base prostate cancers? Are you more worried about moving into the bladder and the ones that are in the base, or bladder neck involvement?
The only thing is, if you're up in the bladder neck, you have the issue of potentially getting into the seminal vesicles.
Yeah.
But in terms of their aggressiveness or morphology, they're similar.
You mentioned something about laterality, that bilateral on both sides of the prostate's more concerning than a unilateral, right? Is that what
It's one more factor. It's not a rule out or rule in active surveillance, but it is one more factor.
And what's extraprostatic extension visually? Extraprostatic extension, I can tell you in my 35 years, sounds different to different people. Is this essentially something growing on the outside of an orange, but is it not necessarily touching anything else? It's like a spot. How do I visualize an extraprostatic extension, and should I be worried about that word?
Right.
Word.
So I probably should put that in my lecture. I'm glad you mentioned it.
I'm going to be your agent.
Absolutely. So you can see on a pathology needle biopsy.
Yes.
The only way you can diagnose extraprostatic extension is if you see tumor in fat, because with rare exception, you don't have fat in the prostate. So if I see cancer glands in the fat, I know it's out of the prostate. And that also would, to me, be a contraindication for active surveillance. If that tumor is already out of the prostate, you know, you don't want to let that sit there for another 10 years growing out of the prostate to the point that if you decide to treat it, it's not going to be treatable at that point.
So it's cancer that's in the fat. So the periprostatic adipose tissue or fat, it's moved into that. They're not an active surveillance candidate. It doesn't mean you necessarily are going to have spread everywhere, but it is a different scenario.
Right. You can still be people. I think patients often get confused. Like if the tumor is out of the prostate, that's it. I'm done. I can't be cured.
Yes.
And that's not true at all. Vast majority of patients with local tumor out, not talking about metastatic disease to a different organ, but if you just have some tumor creeping out of your prostate, vast majority can be treated with radiation. It might be higher doses with surgery, it might be getting a little bit wider margins, but you can still cure the majority of those cases. But you don't want to be just sitting on active surveillance with tumor going out of your prostate and growing and growing and growing.
Oh my gosh, that is pure gold. What the HE double toothpicks is an index tumor. Why do some people use it and some people don't use that terminology?
Yeah, I'm not a big fan of it. So prostate cancer is often multifocal, meaning you have more than one tumor.
Yes.
A lot of times you have one major tumor and then some tiny little ones. And so we tend to call the major tumor index tumor, but usually that's the highest grade, the biggest tumor. But sometimes you might have a higher grade, a big 6 and a small 7. I would call the index tumor the 7 because to me, grade is more important than size. Somebody else might say, well, the big, I'm going to call the index tumor. So the term itself, probably not that great.
Margin status. When someone says it's margin status positive or negative on pathology, do I lose sleep over that? What's margin status?
That's only going to be in a radical prostatectomy. You can't do margin on biopsies. Margin means the surgeon hasn't been able to get the tumor out, the entire tumor out. Some of these cases with the margin positive is an artifact where, there's barely like 1 or 2 glands there. And probably when you get healed and all this tissue gets killed after the surgery, it's going to wipe out those couple tumors. So it probably doesn't mean anything. But sometimes it means that there's an increased risk that tumor is going to come back, that you've left tumor in the patient. So it's important on a radical, not just to say margins positive and negative. You want to say how much tumor is at the margin and what's the grade of the tumor at the margin. So a little bit of 6 at a margin, I wouldn't say you need radiation or any other treatment. But if I had a little bit of 8 at a margin, I would say get radiation after surgery. Or if I had a lot of 6 at the margin, I would say get radiation after surgery.
So the margin should be more individualized. Do you feel that way about extraprostatic extension too, since you said it's in the fat now, or not necessarily?
Not really, because I wouldn't necessarily treat based on extraprostatic extension. Whereas margins, you're trying to decide radiation or not.
Why do people think of perineural invasion as binary? It's in one sample. Isn't it possible that more than one sample can have perineural invasion? Why?
Yep.
I think people think it's all or nothing. So in other words, if I have 6 samples that have perineural invasion versus 2, is that more concerning? I mean, is there, in terms of the amount of perineural invasion, or is it just whether you have it or not in the pathology?
Yeah. There hasn't been good data to say more perineural invasion is worse than limited perineural invasion.
I've never asked this question of anybody. No one's ever taught. Seminal vesicles, there's 2. There's 2 seminal vesicles. So it's not a seminal vesicle, it's seminal vesicles, right? You have 2. If you have disease, I don't even know if anyone's ever been asked this. This is my mind on sometimes caffeine. If both seminal vesicles are impacted by cancer in a pathology report versus 1, is that more concerning or not necessarily so?
They're both bad. So from the standpoint of any kind of prognosis, it's probably not that different. Bilateral seminal vesicle invasion, when it's both, it's usually just even worse disease, but they're both bad.
Finally, on this one, total tumor. Why is it that a lot of cancers out there, tumor volume is everything? Just the gross amount of tumor that exists there. But total tumor volume, I mean, you talked about with this Gleason pattern 4, but total tumor volume, is that going anywhere? Just the total amount of cancer. And I'll tell you where I get most confused by this. I will see you'll see a paper or you'll talk to someone that has Gleason grade group 1. They have a 3+3 and they have a little bit of it, no big deal. But then there's other surgeons that say there's a ton of Gleason 3+3, and sometimes that's not the same as having a little bit of 3+3, and that kind of volume or amount is more concerning, even though they're active surveillance. So, do you have any comment on that?
Yeah, so the only issue is if I had a crystal ball and I saw somebody had a big Gleason 3+3 in there and it was pure, I wouldn't be worried about it. But there is a correlation that the larger the tumor, the higher the risk there may be some pattern 4. So if you have somebody with like 1 core of 5% pattern 3 versus somebody with 10 cores of 3+3, you worry about that 10 core 3+3 that there is 4 somewhere in that prostate. But again, if they can go on active surveillance, and if they keep on having only 3+3, then it's okay.
These are the last miscellaneous ones. Then there's just one thing on part 6 and one thing on part 7, and we're done. Are you hanging in there?
Yep, I'm good. I can hang out until about 2:20.
No, I'll be done before 2:20. Famous last words, but I will be done because this is the most I've ever sat down with a pathologist and got the tertiary Gleason score. I thought the primary and secondary was good enough. Do I have to ask for a tertiary Gleason score, a third report? What the HE double toothpick does that mean? And should everybody report a tertiary?
So that's only in a radical. You should never see that term on a biopsy.
Okay.
In a radical, you can have, for example, a 3+4 with just 1% pattern 5, and same thing, a 4+3 with 1% pattern 5. So in that scenario where the 5 is so little, we don't want to call it a 4+5 or a 3+5. So we say 3+4 with tertiary 5 or 4+3 with tertiary 5. It worsens the prognosis somewhat, but not as bad as like if you had a lot of 5.
Okay, so it's a little bit of a hint of a slightly worse prognosis. Yeah. And that's mostly utilized if it's a more aggressive component there on the tertiary.
And that's only in radicals.
And that's only in radicals. As we jump around here, never heard anyone ask you this. Every other cancer I'm reading, whether it's friends going through it, other people I'm dealing with, you hear this term called tumor infiltrating lymphocytes. It's getting a ton of attention in aggressive breast cancer. You'll see these immune cells that just come into the tissue. And it's supposed to be a good prognostic indicator, for example, of someone that might respond to immune therapy. But it means the immune system is recognizing this as cancer. They call them TILs. Do you deal with any of this stuff, or do you think this has any place in prostate, or is prostate too cold immunologically?
Yeah, it's basically what you just said. Prostate just doesn't seem to attract those TILs, and consequently, it is relatively cold immunologically, and that's why immunotherapy is not, a major, treatment for prostate cancer.
You still watch the old shows. People get frozen section analysis during surgery. Do you still do what is frozen section analysis that pathologists get, or do they still have value today in your job?
They potentially have value. What the whole purpose of when you have surgery, we're not talking about a biopsy typically. You're talking about, let's say, a radical prostatectomy. You might have to wait 2 days, 3 days, a week to get the report. But there are sometimes the surgeon wants to know something right while they're doing the surgery, which may affect how they do the surgery. So you can do a frozen section analysis where basically you take the tissue, from the specimen, you freeze it, literally make it hard with ice, liquid nitrogen, and you generate a section. I would say it's not that commonly done. It used to be done that if there was a positive lymph node at frozen, they would stop the radical. Now they often would go ahead with the radical, even if they saw a small positive node. So unless they see something very unusual, most of the time they don't do frozens. But there are some exceptions. I mean, there's a couple institutions that do hundreds of, tens of frozen sections looking for margins. Entire margins they'll do with frozen sections. But that's rare. I would say most places are not doing frozen sections for prostate.
Here, the last word on this part, and then boom, we'll definitely be done by 20 after. Here's a term I've never seen in a pathology talk, and I understand it for patients, but I think it's time for patients to understand your opinion on it. And I always feel like, since I know you, you're probably bubbling inside. It says, what is this guy about to throw at me? But I think this is a very softball question. But this, what I'm finding before I show you what it is it's incredibly subjective. I'm sure some of it is not, but this has become sort of a wild, wild west of pathology. It's called immunohistochemistry. So you're using all these stains and you're looking at markers or antigens and you're staining the sample and you're trying to decide this and that. And I've seen some that say, well, this is a metabolic stain and this does this. Can you just break down why immunohistochemistry is used much in pathology, and is there standardization, or how should a patient look at this?
Yeah. So what I would say for the patient is, for the most part, ignore the stains. Just
Okay.
look at the diagnosis. Having said that, the stains can be the stains are used to help make the diagnosis, but the stains have a lot of pitfalls. And again, an inexperienced pathologist can use the stains incorrectly and to arrive at a wrong diagnosis, calling something cancer when it's not, vice versa. So, as a patient, again, you don't have to worry about the stains, but just recognize that stains are critical sometimes and have to be interpreted correctly.
Part six and part seven are basically the end. Part seven is the end. Part six is, you mentioned this briefly in other talks, neuroendocrine prostate cancer. I think there should be some awareness by patients for it, because now with the use of a lot of different hormone type therapies, the second generation, I would guess that the number is going to increase. And can you just give a quick background on, this is a very aggressive variant of prostate cancer, and you also look for this when you do second opinions or you look at other samples, right? But can you give us sort of the Epstein thought on neuroendocrine prostate cancer? Because it's something, of course, nobody wants.
Right. So you'll hear the term neuroendocrine cancer. You'll hear the term small cell carcinoma of the prostate. They're basically similar. They're the worst form of cancer that you can have.
Mm.
You don't grade them. You don't give them a Gleason grade. It's there. Once you say that term, small cell carcinoma, then you basically know that these are extremely aggressive. The other thing is that they don't respond to hormone therapy. As you mentioned, you have to treat them with chemotherapy like you would use for a lung small cell cancer or a high-grade neuroendocrine cancer. It's a relatively rare, even though we're seeing it with greater frequency now than we used to, they're still rare.
But you're seeing it pick up, but it's still in the rare category.
Right. Right.
Yeah. Because you mentioned in a lecture that a lot of them have a short interval to me. They become androgen independent, for example. And a lot of them make very little PSA. Isn't that true?
Right. So yeah, they're very different actors than usual prostate cancer. They spread to different sites. They don't make PSA.
Okay.
But again, in the active surveillance realm, you're never going to see that for sure.
Okay. The last one I have is that, all these GLP-1 drugs, these weight loss, before I go into the gift and the quiz, these GLP-1 drugs, I have to talk to them a lot. I published a review article in urology. It got a lot of attention because I just am trying to have urologists just catch up with the idea that these GLP-1s are here to stay. Have they studied yet the impact of these weight loss drugs on prostate tissue, or you haven't seen that?
I haven't seen that. It'd be interesting, but I haven't
It
seen
would
it.
be really interesting, wouldn't it? It makes me always think, if you had $100 million, someone gave you $100 million for research, I always wonder what research study you would want to do the most. Do you want to answer that before we go to the end? If you got $100 million, you could pick one research study that you wanted to really do to get an answer to a question. What would that be?
Right now, I'd probably do the Gleason 7 long-term follow-up active surveillance, looking at every parameter you could potentially look at to see who's a candidate and who's not.
Oh, good answer. Part seven is the final part. Free for all, fun quiz, gifts, and conclusions. We made it. I had a goal of going through seven. This is why I call it the master class, the Epstein and Moyad master Q&A class. This will be legendary. All right, you ready? I'm going to finish off with a quiz. You don't have to answer it, but I'm a big history buff. It's called Dr. Moyad's first time ever Donald F. Gleason quiz. True or
Okay.
false? Ready? Here are my true or false questions. This is for the audience. It's not just for Dr. Epstein. I wouldn't necessarily expect you to know any of these. True or false? Dr. Gleason moved to Paris because he really wanted to be a painter before he went on to practice medicine. True or false?
If I had to guess, I would say true just because it sounds so crazy.
It is absolutely true. And don't you find it interesting that
Yeah.
after he decided he couldn't make any money, he wasn't very good, and his wife said, you're really not good either, apparently. They moved back to Minnesota, and then he got into his practice. But it makes you wonder what he learned to help him
Yeah.
draw the
Yeah. It's
Gleason
amazing.
patterns, right?
That's
So,
wild. Yeah.
yeah, so he
I
did
mean,
do.
I always think of pathology as you have to be extremely visual. I mean,
Yeah.
I love photography. I mean, that's like my art form. And it's the same thing as painting in a sense. It's different, but it's visual. So obviously Gleason was a very visual person and he just translated that into his observations and his drawings. So yeah, that's amazing.
That is amazing. And he was also apparently a big time cook. He loved to cook and he loved to sail. And he would bring a lot of the stuff that he cooked to the residents and the students. So it's such an interesting history. True or false? Dr. Gleason lived across the street from his medical office so he could work all the time and just come home and eat and then go right back to work so he could work all the time.
I'd probably say true too.
That is absolutely true. All right. Number three, the hardest of all. Dr. Gleason, by the way, they say Dr. Donald F. Gleason. F is Floyd. I'm not going to ask you that question. That's too difficult. Because I don't know I know your middle initial. I've never known what your middle name is. All right. Last true and false question, then you get your gift sent to you. And you have made my day on this. I have literally covered everything I wanted to cover in the history of our relationship. True or false? Dr. Gleason died or he passed away from prostate cancer at the age of 88 in 2008 in Edina, Minnesota. Is that true or false that Dr. Gleason passed away from prostate cancer?
I know so many luminaries who have died of prostate cancer, but I'll say true.
You're going to say true?
Yeah.
It's actually false. He
Oh,
died of
that's good.
cardio. I'll tell you why. I'll tell you why I put this question in. I don't expect anyone to get it. It's because it kind of pushes my preventive medicine mantra. He died of cardiovascular disease, apparently had a heart attack. And I find it ironic, interesting that we always say heart healthy is prostate healthy, right? I always try to say that heart healthy is prostate healthy. And the grandfather, the emperor of Gleason, Gleason himself, passed away from cardiovascular disease, which should give you cardiovascular awareness as well as prostate cancer awareness. But at the same time, he was 88. He worked like a dog. I mean, but you did well. Actually, I didn't know you were going to get any of those right. So as a gift, just to show you how much I listened, I talked to you on the phone a couple months ago when we agreed to do this. And you said something to me that resonated. So I thought there's only one gift we're sending to you. So we're sending this to your place. We're sending you a cup that says the best pathologist and even better father. Do you know why I'm sending you? Because at the last second, because you're always on the run, and you're going to have to run here in 2 minutes. You said, I love being in New York. I love this new life. He said, I think you said, correct me if I'm wrong. I'm going right now to my kid's swimming practice. I could have never done that before. I think,
That's what I'm doing at 2:20. I'm running to get my son to take him to swim practice.
really?
Yep, 100%.
So then I thought, who says that? Who puts that? That was so endearing that it stuck in my mind. So PCR and I have spent forever looking for best pathologist and even father. So don't throw it away. That's coming to your place. We have your home address.
Thank you.
Listen, without sounding maudlin or sounding like an Oscar speech, thank you. I mean, you didn't know any of these questions coming at you for an hour and 15 minutes. We discussed no questions beforehand, what I was going to tell you, what I was going to review, and it was just masterful. It was outstanding. And I hope as people go to the website, look at his email, we'll put the email up there and how to get a second opinion from Dr. Epstein. So thank you so much for doing this again. I really appreciate it.
It was wonderful. Totally amazing. I appreciate it.